Good morning, everybody. Welcome to Georgia Heart Grand Rounds. This program is brought to you by Georgia Heart Institute. Any financial relationships of the planners have been mitigated. Our speakers have no financial relationships with commercial interests. If you have a question for the presenters, please wait until the Q&A segment. The evaluation will be shared at the end of the program. If you're watching online, you may submit your questions in the Q&A section, and we'll read it aloud. Your evaluation link will be posted into the chat section, so be sure to check that section to get your evaluation. And now it's my pleasure to invite Dr. Aguilam up to introduce our first speaker.
All right, so next, really gives me a great pleasure to introduce Dr. Daisy Ngwainmbi. As you guys know, she's one of our final year cardiology fellows at the Northeast Georgia Medical Center. She was raised in Fayetteville, North Carolina, and did her medical school training at Ross Medical School, School of Medicine, and subsequently completed her internal medicine residency at the East Carolina University Health Center. She's very honored and was a major part of our first year class of fellows and really was part of that inaugural group that came in to join our fellowship program. As you know, she's completing her training this year and currently interviewing, as she tells me. And her major interest areas are around women's cardiovascular health and preventative cardiology. Please join me in welcoming Dr. Ngwainmbi to the stage.
Good morning, everyone. Thank you for that introduction, Dr. Aguilam. So my topics today, I will be discussing peripartum cardiomyopathy, advances in diagnosis, management, and long-term outcomes. I have no disclosures. Some of my objectives today is to outline the epidemiology and global burden of peripartum cardiomyopathy, highlight key pathophysiological mechanism and risk factors for PPCM, go through the diagnostic criteria and some differential diagnosis for PPCM, and of course explore evidence-based management strategies for PPCM, among other objectives. So, peripartum cardiomyopathy is a rare idiopathic cardiomyopathy presenting with heart failure secondary to LV dysfunction, LV systolic dysfunction towards the end of pregnancy or up to 5 months postpartum. This was termed initially in 1971 by Dr. Demakis, and the definition outlined there is a consensus between the AHA, ACC, and European Society of Cardiology. It's important to understand that peripartum cardiomyopathy is characterized by its rapid clinical course and high probability for spontaneous recovery. I want to make sure that we understand that the LVEF for peripartum cardiomyopathy has to be less than 45% with or without evidence of LV dilatation, and we have to be sure to rule out pre-existing cardiomyopathies. The picture above kind of outlined the global incidence of peripartum cardiomyopathy, and as you can see in red, a lot of the cases were mostly identified in Haiti and Nigeria. As I mentioned, the incidence of peripartum cardiomyopathy is higher in developing countries. This may be due to some environmental and genetic factors, along with certain cultural practices and standards of perinatal care. As outlined in Nigeria, the incidence is about 1 in 100 patients, and in Haiti, 1 in 300 patients. Now, the incidence in the US is rising in about 1 in 1,000 to 4,000 patients. This incidence is rising due to advanced maternal age, multi-fetal gestation secondary to IVF, and disease recognition. And as you can see, farther east, 1 in 20,000 in Japan. So what are some of the risk factors? Now, I want to make sure that we understand that these risk factors are associated with a higher incidence of PPCM, but there is no actual causal association. There are no large population-based studies on the incidence and prognosis of peripartum cardiomyopathy. Multiple statewide studies report that PPCM occurs in about 3 to 16 times more in African-American women than whites. Older maternal age, specifically age greater than 30, and 1/2 of the cases of PPCM occurs. And one study actually reported that in women greater than 40 years old had an odds ratio of 10 of developing the disease compared to those less than 20 years old. Of course, multiple gestations has reported a case of about 7 to 14.5% of PPCM cases in the U.S. Medical comorbidities that are associated with PPCM include pre-existing hypertension, gestational hypertension, obesity, and autoimmune conditions. Of course, lifestyle like smoking or illicit drug use can be associated. And there are some genetic associations with patients with family history of dilated cardiomyopathy or pre-existing PPCM that are associated with new onset PPCM. This is just an outline of some of the demographic factors above, comorbid factors to the left, and genetic and biochemical factors associated with developing PPCM. Now, the pathophysiology of this condition, there actually is no proven mechanism for the development of PPCM, but there are several hypotheses that have been suggested. It's been postulated that PPCM is a vascular disease triggered by hormonal stress of pregnancy, immune system activation, and may have some contributions from nutritional deficiencies. Some of the nutritional deficiencies that were outlined was coming from West Africa, specifically in Nigeria, where certain cases found that patients with PPCM had deficiencies in selenium and ceruloplasmin. There are some viral contributions, but this is not well understood. In summary, the changes, the pathophysiology boils down to 4 things: hormonal changes, which is related to a prolactin hypothesis, vascular dysfunction or anti-angiogenesis, which is the anti-VEGF hypothesis, inflammation and immune system activation, and prior genetic disposition. This picture just kind of outlined the changes that have been hypothesized to lead to peripartum cardiomyopathy, specifically the hormonal hypothesis, where there is an increased level of a toxic form of prolactin, which is induced by increased oxidative stress from pregnancy, late pregnancy, or delivery. Of course, vascular endothelial dysfunction and changes in the placenta that release the molecule that inhibits VEGF production. And ultimately, all of these will lead to cardiomyocyte apoptosis and death. So I'm going to highlight each of these changes. Now, this outlines the hormonal changes related to the prolactin hypothesis. Now, it's important to understand that prolactin is a pituitary hormone, and it is essential for lactation and pregnancy adaptation. Increase in oxidative stress with late pregnancy due to mitochondrial dysfunction, inflammation or immune system activation, and placental hypoxia leads to an activation of an enzyme called cathepsin D. This enzyme is responsible for cleaving prolactin to its toxic form of 16-KD form, and this form inhibits nitric oxide production, leading to vasoconstriction, impaired cardiac perfusion, microvascular dysfunction, and actually directly induces cardiomyocyte apoptosis. Now, I will outline later on that there have been some successful treatments with bromocriptine, which is a prolactin inhibitor that's actually experimental phases that has shown promises in managing this condition. Moving on to our second pathophysiology, vascular dysfunction. The maternal cardiovascular system relies on vascular endothelial growth factors, VEGF, to support pregnancy-associated angiogenesis. The placenta, the syncytial trophoblast cells of the placenta release FSLT1, soluble FMS-like tyrosine kinase, which is an antagonist of VEGF and placental growth factors. And it's important to note that in studies in preeclampsia, multiple gestation, and in PPCM, there's very high levels of SFLT1. Now, this tyrosine kinase goes and binds and inhibits VEGF and placental growth factors, which in turn leads to coronary microvascular dysfunction, myocardial ischemia, and fibrosis formation. This graph or picture kind of outlines some of the changes that occur with pregnancy. In yellow here, we see in second trimester, there's an increased volume plasma volume and cardiac stroke volume and cardiac output. And as pregnancy progresses to delivery, there's increase in levels in estrogen and progesterone that will peak and drop. And of course, in the light pink line, you can see there are levels of SFLT1. But in the case of, increase in stress in delivery and in preeclampsia, there's extremely higher levels of SFLT1, which kind of, support the hypothesis that PPCM is associated with preeclampsia. As well as this picture here, this is just kind of showing the relative levels of prolactin and SFLT1. And as you can see, at closer to delivery, those levels do peak and will decrease. And also showing in the graph at 1 to 4 weeks, the incidence of PPCM is outlined there. Moving on to further pathophysiology, we talk about inflammation and immune system activation. PPCM has strong immunological and inflammatory components with increased levels of pro-inflammatory cytokines such as TNF-alpha, IL-6, and interferon gamma. As I mentioned previously, there are some overlaps with viral cardiomyopathy and where an endomyocardial biopsy showed inflammatory infiltrates in subset of patients with PPCM, specifically parvovirus and Coxsackie virus. So this is warrant that maybe increase in inflammatory markers like CRP, IL-6 can be biomarkers for PPCM, possibly. There are considerations for treatments given that there's an inflammation and immune system activation portion of this, and I'll outline that later. And genetic predisposition, the prevalence of mutations associated with familial dilated cardiomyopathy genes in patients with PPCM suggests that there may be an overlap with the clinical spectrum between these two diseases. It was mentioned that 15 to 20% of PPCM patients have a first-degree relative with cardiomyopathy, suggesting a genetic predisposition. In Figure 2, this is just a localization and function of PPCM-related associated genes and their functions within a cardiomyocyte. And it's important to point out that a lot of these genes are compromised in the cardiac sarcomere. So this is just an outline of the pathophysiology which I discussed. And at the bottom there, you see the placenta. With the placenta, there is a downregulation of STAT3 signaling pathways that leads to decreased level of manganese superoxide dismutase, resulting in increased level of reactive oxygen species, which induce increased levels of Cath that induces the production of the toxic form of prolactin that directly affects the vasculature and the cardiomyocyte, as well as the placenta releasing SFLT1, which inhibits VEGF. And of course, this also has anti-angiogenic factors and direct cell death, increase in hemodynamic and metabolic stresses in pregnancy. With the changes that occur, the cardiomyocyte essentially cannot adjust and overcome volume. And as I mentioned before, there are some viruses, but those exact mechanisms are not well understood. So what are some clinical presentations of peripartum cardiomyopathy and physical exam findings? Unfortunately, a lot of the early signs of this condition are overlooked in pregnancy, and a lot of times we just say this is normal changes or normal changes that happen with pregnancy. But generally, these patients may present with fatigue, decreased exercise tolerance, persistent dyspnea, orthopnea, cough, lower edema, and ascites. On physical exam, you may find changes related to left-sided congestion, right-sided congestion, and S3 could be heard or should be heard in these patients, and usually the EKG is very nonspecific. Diagnostic testing, of course, basic lab, CBC, CMP. In a normal pregnancy, there should not be elevated levels of troponin or BNP. In some subset of patients, late pregnancy, there might be a slight elevation, but you want to make sure that it's not related to preeclampsia or pre-existing cardiomyopathy. But in patients with PPCM, there's a very high level of BNP, specifically severe cases, BNP levels above 2,000. Of course, you want to check a D-dimer with patients presenting with the symptoms I mentioned before. You want to make sure there's no PE. EKG chest X-ray may show signs of pulmonary congestion, effusion, and an enlarged cardiac silhouette. The gold standard for diagnosis of PPCM is the transthoracic echocardiogram, along with the development of heart failure within late pregnancy of 5 months. On the echo, we are looking to see an LVEF less than 45% with or without the evidence of LV dilatation and hypokinesis. It's important to understand that if there's evidence of RV dysfunction, this actually offers a worse prognosis. If cardiac MRI is pursued, you are looking for signs of myocardial fibrosis, which also is a worse prognosis. But understand in pregnancy, gadolinium is prohibited. Endomyocardial biopsy could be pursued if there's any concern for fulminant myocarditis. The management of PPCM warrants a multi-team approach, including obstetrics, cardiology, and anesthesia to plan out the timing and mode of delivery. But generic management of these patients is standard heart failure therapy, including loop diuretics, if there's concerns for volume overload, beta blockers. ACE ARBs are prohibited in pregnancy, but recommended in the postpartum period, as long as spironolactone, which is the only aldosterone antagonist recommended in the postpartum period. If the patients are unstable and require more support, IV vasodilator therapy, specifically nitroglycerin, is recommended. It's important to avoid nitroprusside because there are concerns of cyanide toxicity. And if there's a warrant for a cardiogenic shock and you need inotropic support, studies have shown that milrinone, and in Europe, they use levosimendan. And if the patients are unstable despite inotropic and vasodilatory support, then there warrants a need for mechanical circulatory support, including IABP, Impella, or ECMO. In 5 to 10% of the cases, in 5 to 10% of the cases, there have been a heart transplant, and it is okay to consider wearable cardioverter or defibrillators if there is persistent severe LV dysfunction as a bridge to recovery or until implantable ICD is indicated. This slide is very busy, but this is just outlining what I spoke about previously on the management of these patients, specifically during pregnancy, and on the far left during lactation. Now, there are some emergent therapies that specifically target PPCM in addition to standard therapy. As I mentioned before, the prolactin hypothesis, there is direct prolactin inhibition that I'll talk about a little bit more. There are monoclonal antibodies targeting SFLT1, antisense therapy against microRNA 146A, recombinant VEGF therapy. Some studies have shown plasma exchange to remove excess SFLT1 has shown benefits. Of course, immodulatory therapy against inflammatory cytokines has been considered, gene editing and stem cell. Now, this was the first prospective randomized landmark multicenter trial conducted in Germany and was published in the European Heart Journal in 2017, looking at bromocriptine treatment for peripartum cardiomyopathy. The aim of the study was to assess the LVEF improvement following treatment with bromocriptine in addition to standard therapy. The sample size was small. There were about 140 patients, out of which only 63 underwent randomization. And each patient with an LVEF of less than 35% were randomized to the short-term group, which included 1 week of bromocriptine at 2.5 milligrams, and the long-term group, which was bromocriptine 5 milligrams for 2 weeks, followed by 2.5 milligrams for 6 weeks, in addition to standard therapy. The primary endpoint of this was a delta change in LVEF from baseline to 6 months, assessed by cardiac MRI. And the secondary endpoints was looking at hospitalization for heart failure, death, need for transplant, or LVAD. This is an analysis of primary endpoint. Looking at A, we are comparing the one short-term and a long-term treatment. It's important to note that the delta change of LVEF was about 11% in the 1 week group versus 24% in the long-term group, but the p-value was 0.381, which was not statistically significant. There was a subset group analysis looking at patients with LVEF less than 30%, and ultimately the LVEF change was about 4.7% in those treated in the long-term group, which had a p-value of 0.22, which of course was still not statistically significant. Although the p-value was not statistically significant, it showed a trend to LV recovery with a mean LV improvement in the long-term group of 25%. The final status based on the treatment duration of bromocriptine was outlined here. And just comparing the short-term in 1 week and long-term 8-week course, it's important to point out that the LVEF reduction, persistent LVEF less than 35% was lower in the 8-week group, and the complete recovery was about 68% in the treatment group. I mean, in the long-term treatment group. So there were some limitations in the study, and major limitations include the fact that the sample size was not, the patients, there was only about 63 patients, and, there was no standardization for patients that were controlled, so it was either short-term treatment or long-term treatment. So either way, there were some benefits in receiving bromocriptine therapy, but there are some ongoing researches right now, and I'd like to highlight one, the Rebirth trial, which looks to actually look at a control group and a treatment group with bromocriptine along with standard medical therapy. This is an ongoing trial currently at phase 3 right now, and is projected to end in December 2028. The primary endpoint of this trial is to assess the LVEF at 6 months between both groups, and secondary endpoints of LVEF at 12 months and 3-year follow-up showing survival-free from major events including heart transplant and durable LVAD and hospitalization, heart failure hospitalizations. So what is the prognosis and outcomes? It's important to note that the LVEF at the time of the diagnosis of PPCM is the most reliable predictor of adverse events or long-term recovery. Factors associated with poor prognosis include an LVEF less than 30%, evidence of LV dilatations, evidence of LV thrombus, or RV systolic dysfunction. Unfortunately, African American ethnicity is strongly associated with lower rates of recovery, longer recovery time, and a higher incidence of adverse events and mortalities. There have been suggested that biomarkers associated with adverse outcomes include troponins, NT-proBNP, and high SFLT1 levels. Specifically, the LV dilatation mentioned was about 6.0 centimeters. Complications of PPCM include, brain injury, thromboembolism, and this thromboembolism is secondary to the hypercoagulable state of pregnancy, cardiac dilatation, dysfunction, and venous stasis, and a lot of these patients are on bed rest or may have had post-op C-section. Cardiopulmonary arrest requiring MCS, cardiac transplant, and death. Mortality rates differ based on ethnicity, geographic location, and the duration of follow-up. And as I mentioned before, through the studies, higher mortality rates are reported in Haiti and Africa. So PPCM, as I mentioned, is associated with high rates of recovery compared to other heart failure cardiomyopathies with reduced LVEF. Recovery rates within 3 to 6 months are about 50 to 60%, but can take up to 2 years. Some patients may have persistent cardiomyopathy, and that's outlined in like 30 to 40% of patients. Mortality rates within 5 years is about 5 to 10%. And according to the IPAC study, which I'll outline later, that assessed 100 patients, 100 women with PPCM, that showed about 72% recovery to LVEF greater than 50% at 12 months. So this was one of the summaries from the IPAC study, clinical outcomes of peripartum cardiomyopathy in North America. On the left-hand side, this was taking a look at adverse adverse events, including death and patients undergoing LVAD. And as you can see in the dotted blue line, these are patients with LVEF greater than 30%, and there's no change in them requiring LVAD or death. But in the patients with LVEF less than 30%, there was increase in the incidence of those things, and that was with a p-value of 0.04, which was statistically significant. On the right-hand side, this is also kind of breaking down the change in LVEF in patients with LVEF in less than 30% and greater than 30%, as you can see. And on the right-hand side, about 86% of patients with LVEF greater than 30% had recovery to LVEF greater than 50%. But in those with LVEF less than 30%, it was only about a 37% improvement in LVEF. So general counseling outlined here, it's just the recommendations of patients who are diagnosed with PPCM and are considering subsequent pregnancy, depending on the LVEF at the time of diagnosis. And, generally it's recommended against pregnancy, but if they choose to pursue pregnancy, then it's recommended that they have an echocardiogram prior to conception, and at each point in the first trimester, second trimester, 1 month to delivery, after delivery, and 1 month after delivery, at discharge and after delivery. And as I mentioned before, LVEF before the subsequent pregnancy is the strongest predictor of outcomes, with worse outcomes among women whose LVEF does not normalize. This is a very busy slide as well, but I just want to highlight in purple at the top, I mentioned before preconception counseling, and a lot of these patients are advised against pregnancy, and to pursue alternative ways of building a family. But if they choose to pursue pregnancy, certain things have to be met, certain criteria have to be met. These patients have to be followed with obstetric, high-risk OB, and cardiology. This is just a summary of my whole talk and references. Thank you.
All right, thank you, Dr. Ngwainmbi, for that enlightening presentation. We'll see if there's any questions in the audience or any questions online.
Thank you so much for this presentation. You really covered a lot of options that we can do, but I think the options are limited given the pregnancy and what you can do. I was curious to know, in your research, in your literature research, have you noticed any evidence and outcomes on delivering early or planning early induction in patients who are already predisposed? Because there's social disparities and ethnic disparities. Have you noticed anything with early induction?
No, I didn't see anything specifically with early induction. I think based on the patient's clinical course, it's been recommended that, it has to be discussed with cardiology. There was a mention that if at least let the women go through at least 37 weeks before you consider induction, and if induced, it's preferred with vaginal delivery rather than C-section. But early induction prior to that point is not recommended.
Yes, thank you for that. I just wanted to ask about the ACE and ABS. It's okay to give postpartum, but is there any effects via breastfeeding? Is it dependent on breastfeeding? Is there any effects to the baby via breastfeeding or no?
I didn't see anything related to breastfeeding. I don't know if any heart failure specialists.
So it depends on which one you use. So there's some ARBs that don't cross into the breast milk. So you'd have to look through and see. I think I'm blanking on, but sort of valsartan or losartan sometimes can be used.
I know we have a lot of staff here, we have residents here, we have fellows here, not many physicians in the room, but I would like to say for Priya's lecture and the cardiogenic shock, we really, really need all hands on deck, from cath lab staff, coordinators, all the clinicians in the room. This is not a one service specialty treatment. We need heart failure cardiologists, we need interventional cardiologists, we need surgeons, we need critical care cardiologists to tackle this problem. And that's the ideal slate. This needs to be multi-collaborative. And as Priya said, this is the highest mortality condition in our hospital of any condition. 50% mortality in the hospital is terrible. So I would urge everyone who's listening to this lecture that think of ways we can come together and deal with this terrible problem. I would really like this to be a collaborative approach here at Georgia Heart Institute and Northeast Georgia Health System. Thank you.
All right, well, thank you, guys. Appreciate
you,
everyone coming
everybody.
out, and look out for the next invite.